Uh, Today I would like to share my experience. I'm not sure if it's right or wrong, but it is my experience that has passed my milestone for the arthroscopic microfracture of the osteochondral lesion of the talus for more than 150 cases last year, and also arthroscopic AMIC close to 20 cases, and open either osteotomy or without osteotomy for 50 cases. So nowadays, I think I passed around 220 cases with the osteochondral lesion of the talus. And the technique that I share, at the end of the day, I hope you may capture some point and then apply to your clinical workings. But if you don't like my techniques, that's okay. Just maybe listen and just sharing. Okay, here's my disclosure. So as we know, the incidence is approximately 4%. It's just the one series of 121 patients that have symptomatic ankle sprain, and these patients were lucky and underwent MRI investigation, and they found osteochondral lesion of the talus. And from 4% of them, 10% of that have bilateral. So sometimes when you see unilateral, and if the patient have no history of trauma, you may need to think about some of the pathology, such as osteochondritic disc scan, which is involved about ischemic process. You may need to think about on the other side as well. But overall, they're higher incident than we expect because majority of the patient didn't go to the MRI. So the concept that we know in 1992, the concept of spontaneous osteochondritic disc scan was proposed, and then Byrne and Hardy was proposed about the traumatic etiologies. And then in 1966, Campbell and Lanawat also proposed the concept of the ischemic pathological fracture of the subchondral bone and damage on the cartilage. I think nowadays we know trauma still be the main or the leading cause of the osteochondral lesion of the talus, and among the injury, rotational ankle sprain is one of the most common. And I want you to look into this picture carefully. So I'm very happy that Dr. Jirawat mentioned about the lateral ligament injury. This is my first lesson that I want to share with you. You can see osteochondral lesion usually happen when the ligament was failed. So otherwise, it's difficult that the talus and the platform will be pinched together. So it means ligament usually damaged at the time of injury. And this thing that you must search for or look for the associated collateral ligament injury. And it can be a syndesmotic injury as well. And sometimes it can be soft tissue and bony impingement that happen after the chronic injury. So this is my first lesson. When I see osteochondral lesion of the talus, I'm gonna look into the patient and try to find collateral ligament. And I don't want to miss this thing. When I found it, I need to fix it at the same time. Clinical presentation, as we know, most of the patients present with dull, achy pain and difficult to localize because it's deep inside the joint. And many patients come with swelling on the ankle at the end of the day after long walking or long standing. And a few patients maybe complain with the snapping sensation or clicking sensation if the flap is unstable and fold around the ankle. An X-ray, I think Dr. Jirawat already mentioned, is something that we always send the patient to check, but like we know, the sensitivity is low. Some paper report only 19%, some may give them up high to 41%. But the good thing is when you see the lytic lesion on the medial or lateral talar dome, they have a highly specificity, I would say 98% plus. So yeah, it's inexpensive investigation, but just low sensitivity. The CT scan is better in terms of improved sensitivity and 99 specificity, but the problem is if the patient have the injury not involved the subchondral bone, you may not be detected by CT scan, or the patient with early of the cartilage, like incomplete injury to the cartilage, you may not see by a CT scan, except you can adjunct the SPECT CT scan, you can early detection of the lesion, but the problem is it's not available in our hospital, especially in this country. MRI, I would say, still be a gold standard in my mind. They have 96% in both sensitivity and specificity. But you need to keep in mind the lesion from MRIs, I would say, it's likely to be bigger than what it should be. And the MRI have the benefit to detect the associated collateral ligament injury as well as the syndesmotic injury. So for myself, so nowadays I would send both CT and MRI if my patient doesn't have financial problems. But if I would pick one thing, I'm gonna pick MRI. This is my current practice nowadays, and I found 60% of my patients have the lateral ligament injury and require the fixation at the same time. And this also support my belief from the study from Dew that mentioned that, okay, they can see the ankle sprain will be the majority of cause of the osteochondral lesion of the talus, and then Barbier report 30%, close to 40% of their series. The patient have osteochondral lesion with significant lateral ankle instability, and they need to be addressed the surgery at the same time. I think they're pretty much close to me, but I maybe found more than them. But I think it's the same line of the things that we found. And I want to show up on the algorithm that we already know that if the lesion less than 10 millimeter, yes, we can do microfracture alone. But if the lesion between 10 or 20 millimeter, you need to do something. Microfracture alone may work, but majority of them is not working based on the recent study that have been found. The outcome is not as good as the small lesions. So for the size of the osteochondral lesion is something that we usually come up with the question, how we know the lesion will fit well with the arthroscopic microfracture. So we can grouping them into things. Number one, in the area of involvement. It means you multiply width and length, and then you will get the area. If it's less than 1.5, at the old day, we believe this is the magic number that we can go microfracture. And if we look into the diameter from Jak Pai Wong or Dr. Bawanit, we found if the diameter less than 1.5 centimeter, okay, we will do well with the microfracture. But so nowadays, they have more and more research publication, I would say more than 400 publication regarding the osteochondral lesion of the talus. We started systematic review on 2016 by Longo, the report. At that moment, they cannot find the difference or the correlations with the size and the outcome of the patients, and they still suggest to use the same number, 1.5 centimeter in the diameter, and also 1.5 square millimeter for the area of involvement. But recently in 2017 from Romponis, they are gathering more and more paper. And nowadays we found that if the lesion is less than 107 square millimeter in the area, they tend to go well with the microfracture. And also the diameter less than 10, maybe go well with the microfracture. But if it's longer than that, you may need to do something. It's not just microfracture will work well. And this is my lesson number 3. I think I'm with them, and I think in my hands, the lesion is big, it doesn't do well as I expect. And the lesion is small, it do better. For the lesion is big, I still do the microfracture, but I need to add on something like PRP injection or scaffold like arthroscopic amix. That's why I need to keep moving to do something for my patients. And one thing is that we don't have the cut point value nowadays. Most of the time they talk about isolated osteochondral lesion of the talus, but they're not mentioned when the osteochondral lesion along with the lateral ligament or medial side ankle instability. You need to keep in mind when you do microfracture, but if the stability didn't get fixed, how it's gonna do well, because the talus can still tilt, the load gonna be like out compared to the normal patient. So I think we still need to know the cut point value from the patient who have like combinations of the collateral ligament and osteochondral lesion of the talus, but we still need the future RCT study. And my third lesson also confirmed by biomechanics study that if you do the lesion greater than 6.6 millimeter in area, we found that this is the diameter that you need to fix. You cannot ignore, because the biomechanics study already proved it's going to be deteriorate over the time. They're going to end up with something. You cannot ignore. If smaller than this, okay, you may ignore if they have no asymptomatic. But if they have symptomatic, you should fix. Or without symptomatic, greater than 6 by 6 millimeter, you should address something for the patients. And also, if it's greater than 10 millimeter, it means they have a lot of stress concentration will be increasing like 3 times compared to normal structure. And this thing need to be surgical treatment as well. So another thing about the depth of the lesions, this is also the question, because I don't know where the magic number come from, but we come up with the magic number like the area and the diameter, as I mentioned in the previous slide. This one we got the magic number 5 millimeter, maybe because of the previous study they mentioned this, and we try to capture this. And I searching like for 2 weeks, I still cannot see nowadays what is the scientific behind the 5 millimeter. It's still difficult to see. But okay, it is what it is, because we have 5 millimeter. I still go with them at 5 millimeter. But one thing that I realize, even sometimes it's less than 5 millimeter, if it's cystic lesion, multiloculated, I think arthroscopic microfracture may not work well, because you need to remove all the cystic lesion and the cyst wall to prevent the recurrence. I think that is much more important than just the number of the depth of the lesions. So this is an example. You can see the multiple cysts like that. You keep in mind you have straight instrument. So no matter what you go, you use a curette, you use a shaver. It's straight instrument. You cannot get out the cyst wall in this location. I would say it's a dead spot for you. I would say in this case, I prefer to use the open technique, which is much more reliable and maybe appropriate for the patient. I know many of you like arthroscopy, but sometimes you need to be give up with the arthroscopy, do something more effective for your patients. Okay, and my fourth lesson for the osteochondral lesion of the talus. If you see a acute fragment, and the fragment is diameter greater than 10 millimeter and thickness more than 3 millimeter, in acute period, I prefer to do fixation. But to perform the fixation, you can use a metal screw, or you can use bioabsorbable. Is one available company is a condo dust from Arthroscopic company. I tried both of them, and I found bioabsorbable is much more easier, and you don't need to remove. Yeah, you can use metal, but sometimes you may need to remove, and you will find it very difficult. I would say use bioabsorbable, life will be more easier, and you don't need to remove. But in chronic setting, there still have no research or evidence to back up what should you do. But I try to fix first. If it fails, then I do something else. I do only 4 cases for chronic. 2 was success, and another 2 was not success. I need to do open and do bone grafting. And this is the technique. Standardly, you're going to use the anteromedial and anterolateral portal for the arthroscopy. And then one thing that I want to mention is about accessory portal. When I graduate and come back here to work in 2015, I rarely use the accessory portal, because I'm scary I'm going to injury to something, injury to the great saphenous nerve, injury to the tibial anterior tendons. I try to avoid, and after I doing the surgery, I found anterolateral portal for viewing is limited in some lesion, especially far medial. You cannot see it well. You need to flip, go back to anteromedial portal to viewing, and go back to anterolateral portal and working again and again and again is waste your time. So yeah, but nowadays the things that I changed my mind. You can see here, this is the viewing from anterolateral portal. Even you use 70 degrees, you may see better than this, but it's hard to working. And take a look on the left-hand side, it's just standard anterolateral portal. and the right-hand side is accessory anteromedial portal. You see it's clearly and easier compared to just the standard thing that people usually do. Yeah, that's why nowadays I shift to accessory medial portal easily. I'm not wasting my time. I just go in and I take care at the same time, and it makes my life much more easier. This is the way that you can see. You can do treatment at the same time. You don't need to switch back and forth, and you can see things clearly. And for the treatments, yeah, this is what outside, how it look on the outside part. It will look like that. Okay, and this is my first lesson, so don't hesitate to use the accessory portal. And then for the microfracture, the depth is about 6 millimeter. This is a good based on the MRI study. From the depth of the microfracture, they recommend 6 millimeter interval between 3 to 5 to prevent the cracking on the subchondral bone. And then for the outcome, Dr. Chiravat already mentioned. So patient 90% return to play, but you need to read this carefully. Can play, it doesn't mean they play like they can do before. So the performance may not exactly the same, but they just can't play. This is thing that I realize from my patients. Many of the study, I think they overstate on the outcome, but in the real world, I don't think it's as that good. Okay, and good for short term only, but long term is not that good. You can look into the more than 50 studies mentioned that the microfracture will deteriorate over the times. Okay, and this is another cases has been done, and you can see after we take a look in the second surgery, you see that they still have the defect, and the fibrocartilaginous, sometimes it doesn't incorporate with the surrounding bone. And then, like I said, my last lesson, if I would have last lesion, I'm not hesitate to do something augmentation like PRP or AMIX procedure. Due to the time's up, I need to go fast. Just some cases that I performed the surgery, and I measured this case is about 14 in length and about 6 millimeter in width. So I decided to do the AMIX, and then we just put the scaffold adjunct into the patients, and this is a final. And then at 1 year, you can take a look. It's much better than the previous cases I have seen to you. But I just done around 17 cases. I have long way to go, and only one case has failed because I always check them at 1 year. 16 cases look like that, but one case doesn't look like this. I would say it's 95% okay in my hand. And then this is my outcome. Okay, my last slide. I think less than 10 millimeter, you can go microfracture. Bigger than that, you need to do something. You can go injection, or you can go AMIX procedure. And deep lesion or multiple cystic, I think open was the key. So thank you for your attention.